Hi, everybody. It's Karen Anderson here with Aortic Hope for our live Q&A with Dr. Prakash. But before we get started, I'd like to ask all of you to please click like, please click subscribe, hit that bell so that you're notified every time we go live. We go live for these types of events. We go live for our Monday Week in Reviews. We go live when we have some very brave souls who want to share their Survivor series and interact with all of you. So go ahead and do that for me. And we're going to kick this off and get started with our kind of sort of new format of our Ask a Doctor with Dr. Prakash. Thank you so much for joining us tonight.
Well, thank you very much, Karen. It's an honor to participate, and I really enjoy these sessions. I feel like it's meaningful, probably as meaningful to me as it is for everyone who participates.
Yeah, it always gives us a lot of great information. I love when I'm able to try to sneak in questions anonymously that really have to do with myself. So before we get started in going through a little bit about yourself and getting into the world of exercise, which it's on everybody's mind, right now, let's talk to everybody and make sure that they understand that these types of events are used for educational and informational purposes only. Please take what you hear tonight and take the information back to your own physician and make those plans with him or her, and let everybody that's on your team make the decisions what's best for you. So now that I've covered that, why don't you go ahead and tell everybody a little bit about yourself, and then we're going to get started.
Great. Well, hi, everyone. For those of you who don't know me, I'm Siddharth Prakash. I'm a cardiologist and genetic researcher at the University of Texas Health Science Center at Houston. I run our aortopathy clinic there, where we see patients with thoracic aortic aneurysms, aortic dissections, bicuspid aortic valve, and many conditions related to those. My job as a cardiologist is really to advise people about the kinds of medications they need to take, how often they should get tested, different kinds of screening, and of course, families that have many individuals who are at risk. We try to do screening to identify people before they actually have a problem that is clinically important. I've been doing that for about 10 years, and during that time, I started to know some of the families and become interested in the questions that they asked because there weren't a lot of resources. So we started to try to create our own resources, first in our clinic and then through the John Ritter Foundation and now through the Marfan Foundation, doing a lot of patient education, kind of outreach and participation with different meetings, conferences, and eventually things like this. So that's something I really enjoy doing. And I hope that it's proven beneficial to people all over. Everyone can benefit from this information. And I think it's incumbent on all of us to increase the education out there.
Absolutely. Absolutely. So tell everybody what you've been working on, because there's buzz. The buzz has been going on way over a year. I mean, we've been buzzing since you were working on research with bicuspid valve, and then the exercise research got everybody in a flurry. So let's go through some of this a little bit.
Right. So about a year ago, we received a grant to start work on an exercise trial. And this trial is for people who have had any type of aortic dissection. The concern is that people have stopped exercising altogether, or at least greatly reduce the amount of activity that they do after dissection. And we know as cardiologists that this is very harmful to your health. Being sedentary in general causes a lot of changes in your body that can make things like high blood pressure worse. Well, high blood pressure is a major risk for aortic disease in general, and is specifically bad after aortic dissection. So we thought that promoting a healthy lifestyle, and especially exercise, could prevent long-term damage in people who've had a dissection and also speed up their recovery, because it's a very long process. And frequently being inactive also means you're weaker and you're less able to recover. So the hypothesis was that if we could provide a guided exercise program for people who survived a dissection, then follow them, we could track changes in their confidence, in their physical activity and ability, and of course their mental health, and especially their blood pressure. So we set out in January to begin to enroll, and the goal was to enroll 120 or so people from around the country all of whom had survived a dissection, and followed them for a calendar year, doing the guided exercise programs at home. We would also test them in the clinic at the beginning and end, so we would have kind of a before and after picture of everyone. And the idea was to get and people in all across the country. So we had 2 other places join us in St. Louis and Michigan to help expand our reach, and that we would then catch up with these folks at home every 2 to 3 months, check in with them, see how they were doing, and collect data from them in the form of surveys and some video chats that we do. So that's been going on now for a bit over almost 7 months, and we are still enrolling. So we are more than halfway to our goal, but we could definitely use your help. It's been tremendous in terms of the outreach, and looking at the map of everyone who's been enrolled. It's literally in every state now. We've got someone. It's all over the country. So we feel like this has been wildly more successful than I thought. I thought we might get a few people around, our clinics, but people are coming from far and wide to do this, and it's actually kind of intimidating when you see how far people are willing to go to get checked out. So to me, that feels like we're tapping into an unmet need in the community, and it's a tremendous honor and very exciting to be able to do this. But I hope that we are still open and enrolling, and we hope that you can join us. And we have contact information that we can post later. But if you contact us, we will reach out to you and make sure that you're eligible for the study first, but then we can make the rest of the arrangements very quickly.
And is there a cutoff date to enroll?
Yeah, so right now our last enrollment dates are in August. So as I mentioned, we're still enrolling through July and August. And we have enrollment dates on Saturdays because we know it's difficult for people to make it to one of the clinic sites during the week. So we've opened up Saturdays, and we can work with you also to find the best time, when you want to enroll.
There will be information here, but also you can go to Aortic Hope's website under resources, and if you scroll down to research, all of the information and contact information to look into enrolling in one of the 3 locations is in there, so that people can find that. And I know people have been looking. And you're so right, and I'm so glad, and I'm not surprised you've had such a large turnout, because we know as a community that the stories and restrictions, everything's all over the place. And I can't imagine there's ever really going to be a one restriction or one prescription to working out that'll fit everyone, because everybody's got comorbidities or different levels that they can achieve. And one of the things that we've tried to do here is at least tell people, well, whatever you've been cleared to do, just do it, because at least you've been cleared to do it. Don't try to compare yourself against the person who's the triathlete, because that just might not be in your personal abilities based on your reaction to medication, whatever the case may be. So because I know you can't give anything defined at this point, but what are some of the trends and things you're seeing?
Yeah, so we ask people, like, what did your doctors allow you to do, just out of curiosity? Yeah. And we get all kinds of answers. I mean, it ranges from my doctor said not to lift any weights, even like 2 pounds, all the way to people who are training for triathlons, after dissection. So, I mean, there's a huge variety. And one of the problems is that there isn't a lot of standardized information so that people really know where they're at in terms of what they're able to do. There's a lot of confusion, and I think that leads to anxiety. So we do notice that for sure. And then a lot of times when people tell us that they're not sure they can do something, it's because they haven't been active for a long time. And after they participate with us and they see, okay, I can actually do this and I feel okay afterwards, I think we can even see a visible change in that first session when we're with them and we're watching them actually do it, and they just feel so much more confident to keep going after that. So I think there's a motivating factor too that we're seeing. And that really has translated into people, just taking off when they get home and they're feeling like they're freer to do things than they felt in a long time.
I think part of this, just from taking the pulse of the community and talking to so many people, is we are so in our mind. We probably the people in this community have the best imagination, because once we know what an aorta kind of sort of looks like from these drawings, is we picture ourselves, okay, if there's an aneurysm and my heart's really working, I'm just blowing it up like a balloon. Well, then I shouldn't do anything. Or I've had a dissection, and how can all this blood be flowing through something the size of a spaghetti noodle? And then we think, well, I'm going to implode and my heart rate's so fast, I need to not do it. And we succumb to this imagined, it's like paralysis that we've created to ourselves. And again, you're right. One doctor will say, don't lift anything above a jug of milk. And you say, it's been 8 years. Why am I still only able to lift a jug of milk? I know I lift my luggage, and you know how much women's luggage weighs. So, if I can pull that out of the trunk, why am I still being told not to do this? And I wonder if some of it is all of the unknown and better safe than sorry. And I still sit here after 8 years. I'm like, how are these people on some of these pages able to do a Spartan race? And yes, that's one extreme. And other people able to jog a 5K. I mean, I know I can put in 18,000 steps. I've been to Universal Studios, and anybody who's been there knows you do that easily. And yet, if I try to go do that on a treadmill, I think I'm just going to die. So, and that's because of lack of activity, lack of it being consistent. So, what do you think is going to be some of this end result? What are you hoping to have as the end result of this? I know what I'm hoping for, but what is the realistic expectation?
Yeah, so we're really hoping to demonstrate first and foremost that everyone can exercise, that exercise is safe, and that has tremendous benefits even right away, beginning with improved mental health and improved, just improved energy and a renewed outlook on life. I think that is missing. It's something that's taken away from you when you have a dissection. It takes a long time to get it back, and anything that we can do to improve the quality of life, I think goes a long way towards overall health, because it is so important to people's life balance, so that they feel like I can get back to doing things that I enjoy, that I can be effective at doing things. Sometimes you feel like, there's a hidden kind of limitation kind of binding you wherever you go. And this may do, if we can erase that a little bit and make people feel more confident to engage in those kinds of activities, I think that we've gone a long way with this study.
I think that is exactly what my goal is. And I wonder, too, the people who are in watch and wait that have an aneurysm, if they're not feeling some of that paralysis, too. I know a lot of people come on and they say, first, what is an aneurysm? Okay, so we need to even back up, because different doctors are defining them and they're using different terminology. But what does that mean that I can or can't do? I read people's responses on Facebook, which nobody should use what you get on Facebook as anything that is solid. And they'll say, well, just don't strain if you go to the bathroom. Don't strain if you're going to do don't do isometric anything. Well, what is their aneurysm, and what is the answer for that? So it's so hard, I think, even for that community as well.
Yeah, I mean, it's funny, when we started this work a little over 3 years ago, and we told people we are going to exercise people that have aneurysms or dissections, they're like, oh, you should start with aneurysms because dissections are just too risky, right? Yeah. We won't accept that, but you can start with aneurysms. So we had people with aneurysms, and so many people with dissections in our clinic asked to join that within a few months, we were also testing them, in terms of exercise, totally safe, totally fine. We actually had controls in that first study, and everyone did great. I mean, there were no adverse events. I mean, if anything, we saw a greater improvement in the dissection group than in the aneurysm group, because they had lost more functional capacity after the dissection. So that's where the idea to test, start with dissections, but for sure, we also want to include people with aneurysms in the next round. Our hope is, after people see this trial, we'll be able to recruit more broadly and now look at aneurysms and also follow people for longer periods. So we can say, hey, does this actually prevent your aneurysm from growing, which would be super exciting. But that takes, a lot more people and a lot longer follow-up. So it's a bigger trial. And for that, we will need to apply to the government for a really large amount of funding. We're hoping to use this kind of result to jumpstart that.
On our last conversation, we went into some detail about what happens in the study. So before we move on to any other topic, can you explain, someone's going to see this, they're going to make that phone call or shoot the email, what happens from there?
Sure. So someone from our team will reach out to you and will explain to you how the study works. The study has three main components. It has a beginning or an admission visit to the study. That is an in-person visit where you go to one of our three study sites here, St. Louis or Michigan. You get tested on an exercise circuit where we do like different types of isometric and aerobic activities. We measure your blood pressure during those activities. We watch your technique and we give you some feedback. So once that happens, you then go home. You get some instructions on how to continue these activities at home, and we check in with you at 1 month and then every couple months after that to see how you're doing. We can give you some feedback, give you some encouragement, and we set goals. Like for instance, depending on where you start, we'll say, well, can you do this much more? And by the time we see you next time, so we're trying to coach you and give you motivation, and also, answer questions if you come across any problems or if you have some difficulties. So the idea is that at 12 months, when you've done this for at home, then we bring you back and we do the same exercise session, same measurements, only now we're comparing them to the beginning. What we expect is, your strength will have gone up, your endurance will have gone up, you'll be able to do so much more, and your blood pressure will be lower. So hopefully, and at the same time, we're also checking mental health. So we have people fill out surveys and to track how those changes are going as well during the study.
Gosh, you make me feel like when I hang up with this, that I should just go to my gym. I feel like this is the part that I'm missing. Look, I'm definitely one of the masses of people who, after the dissection and just, getting used to all the medications, and you feel like you're a zombie, and then you try, but then something happens that knocks you back 2 rungs. And then you find out, oh, you're walking around with 2 big aneurysms that they're watching. And so then you don't do anything. And now your valve is leaky. So then you don't do it. It's like you can do, but then you can't do. And so I cannot wait. I'm so excited and so happy for you and the team of everybody who's doing this, because this is going to make a huge difference for many people. I think they're going to just feel the confidence just in listening. Every time I listen to you talk about it, I start to feel more confident that, all right, well, okay, so maybe I'll go do something. I'll try start small. I'll just take a little walk, around the mall, if people still go to malls, but that always turns into stopping and shopping. It's a whole other different conversation, but it does make me want to try a little bit more. Not ready to join the
that's right.
the thing, but I'll try.
I think one of the things that people will tell us all the time, when we talk to other physicians who are taking care of patients, they will say, but the guidelines say this. And we're like, well, the guidelines are based on 5 people's expert opinion from 20 years ago. Really, that's all it is. There's no data. And so then they'll say, well, show us the data. So that's where the trial came from. We're going to show them the data, and we're going to change the guidelines. And so then everyone will read the same thing. It'll be more standardized. And there'll be good evidence that exercise is safe and effective for this population. That's the real long-lasting effect, I think, that we're hoping for.
Absolutely. And that's with anything else. I mean, when I first came into this community 8 years ago, I'm reading online mortality rates of 5 or 10 years. And I'm thinking, what am I really trying to go for here with recovery if I'm probably not going to be around? And then it took time of being entrenched in the community to realize, well, that's old. That's because nobody that didn't have a known syndrome, they weren't being followed. There was no follow-up. But now we're really that first class of people that are actually getting properly followed up. And so there is no issue now when we talk about mortality. There's no reason why I am not going to live the life I was supposed to prior to this happening, as long as I'm being followed and doing what I need to do. And so, as with anything, with this exercise study, I love the idea that we will come away with a better sense of what the human body is capable of doing. And depending on our situations, it's going to be more than just move your body, which is going to be great. There'll be something that people can actually hold, something tangible. And I love that. Love that.
Great.
And I have a lot of questions for it as well. I mean, I'm just scrolling here and I'm getting questions or just bing. I know you guys, you can't hear it, but I'm getting zapped. So let me ask you, what is the best low impact exercise for someone after they've had a dissection? And also, what if they're on just a watch and wait with an aneurysm?
Yeah, so I mean, in general, when we talk about activity and risk of any sort of bad outcome like cardiovascular disease of any kind or just living longer, the one with the most evidence is aerobic activity. That's moving your body through space, getting your heart rate up. There is a definite increase in longevity and cardiovascular health with each additional hour that you do per week. And that's where the current activity guidelines for Americans come from. The 150 minutes is based on the fact that if you do that much, you're going to live 20% longer. And it's quite an amazing thing. It goes over all ages, all population groups. If you look at the amount of activity people do per week, that 150 is kind of like a magic number. So that's what we tell our patients, aim for that. That's a minimum, but anything over that, you actually get even more benefit. So activity levels really do matter when it comes to your lifespan, your health, all those things, and probably even more so, after dissection because your body is in recovery.
Okay. And then flip side, are there any risks to moderate to high levels of exercise?
Right. So so low to moderate exercises are generally safe and effective for almost everyone. When we get into the high intensity exercise, that is exercise, I define it in a simple term. If you can't carry on a conversation during an exercise, you're at moderate to high intensity.
Okay.
And, if you're so out of breath. So that's kind of a general guideline for people, and it's going to vary depending on your fitness level. So that's when fitness really gets into it. So if you start out at a low level and you build yourself up, you're much more likely to have a safe and effective experience. It's really, when you jump to that high level, if you don't prepare your body, you're going to put your body under stress. And what that means is your blood pressure goes up, your heart rate shoots up, you feel really tense during exercise. And that's not a good thing. If you're feeling that, it means you're doing too much and you should lower your level. Everyone's super ambitious when you start, but you just have to be realistic and start slow and gradually increase your capacity. That prevents things like overload when you get to moderate to high level. And, if you're lifting weights, it would be equivalent to, I can't do another repetition of a weight. I'm so tired. My muscles are completely exhausted. That's not where we want to be. When we talk about healthy, beneficial exercise, we want to give your body a chance to recover. So you stop before you reach that level where you can't do anymore.
Now, you've been doing this study, you're hearing from people of a variety of fitness levels. Are there any things that people should just absolutely avoid when it comes to fitness? I mean, obviously, we're not looking for people to be heavy weightlifters. We all know that. But, I do hear people that are doing these mud runs and these obstacle courses. Is there anything that you think people should avoid?
Well, what I would say is, as a general rule of thumb, heavy weights are probably not a great idea for most people. I mean, off the top, to be super general. The reason why, there are two reasons. One is because heavy weightlifting really requires proper technique, and if you haven't been trained, you can easily hurt yourself in two ways. You can damage your joints, and also you can really raise your blood pressure to dangerous levels because you're straining too hard. And so if you're not really well trained, I would say don't even try to lift heavy weights, because you can get equivalent benefits in terms of your strength from doing low to moderate but higher repetitions. So in most cases, unless you're really aiming to become a bodybuilder, which again, I would not recommend for anyone who has aortic disease, then the lower amounts of weights will do what you want, will get you where you want with lower risk. So that's what I would say in general about that.
Okay.
There are always going to be some exceptions, I know.
Right. Now, I did actually get a question, because again, we're the best with imagination. Somebody did want to know if you can jog with an aneurysm. And I know everybody comes out of having surgery or when they find out they have an aneurysm, and the first time they get a cold, they think I can't, there's no way I can sneeze
I hear that
because
one.
I'm going to implode. It's like women when they find out they're pregnant, they're like, I'm not sneezing because I'm just going to lose everything. And I think
Right.
it's in our head. We think right. So obviously, I'm going to assume jogging's fine if you have an aneurysm.
Yeah, and the way I would say it to people is that the force of blood pumping through your aorta with every heartbeat is far greater than if you sneeze, the kind of pressure on your aorta, or from jogging and it's bouncing up and down. Just think about that. Your entire aorta rocks back and forth every time your heart beats. And there's nothing you can do about that.
Right.
So in comparison to all the other things, that wear and tear 24 hours a day is far greater. And that's why things like blood pressure are so important.
That's so interesting. That's so interesting. All right. Before we move on to anything else, is there I didn't remember if you were going to share anything or not, but I wanted to give you an opportunity. If there was anything else we wanted to talk about with that study. We're good?
No, I mean, I was going to, but I'm afraid to try. So I think as long as you have,
I do. I do. And is there anything else that you're working on right now? Because I know that I think the bicuspid that ended, right?
Yes, we're writing up that paper now. It should be published. We're actually presenting it at a genetics meeting in the fall, and it should be published by the end of the year. So I'm really excited about that, but we're not enrolling for that study anymore.
Okay. All right. So let's see. Long-term effects from a dissection. What would be considered, and I'm curious about this too, because I think when we get to a place of recovery, we really don't think about it anymore. A lot of people go back to work. We just go on about our life, but there are many people that do wonder what is going to be the long-term effect of having a dissection or a residual one.
Yeah, so there are a few things that we look at. The first is the development of high blood pressure later, several years out and later than that. Frequently what happens is that the aorta heals, but in part of the trade-off from healing is that it becomes very stiff and thick because there's a lot of scar tissue. Just like if you injure your skin and you get a scab and a scar, that sometimes that scar doesn't totally go away. It's the same thing on the inside. When you have a dissection, you get a scar in the aorta, and that makes the aorta a little bit stiffer and less bendable. As I mentioned, with every heartbeat, the aorta has to expand and contract as that pulse goes through. That's what you feel in your wrist. And so if it's stiffer, it doesn't quite expand as well. And that means the pressure builds up a little bit more. And so people tend to develop hypertension late after, years after the dissection. That's harder to control. And we think that that is part of the long-term consequence. In terms of other things, we really don't see a lot, fortunately, of other things that we would be concerned about. I mean, originally people were concerned that everyone would get kidney problems. That hasn't really panned out. Most people do fine in terms of their organ health. It's more related to, I think, the overall changes with respect to blood pressure and some things that we can measure now a little bit better than before. And that helps us actually follow people better. We can kind of predict when the changes are happening now and try to hone in on that and prevent changes related to high blood pressure before they happen.
Okay. Aneurysm, or is it a dilation, or is it a mild enlargement? All three words. What starts and what's next and what's next, and how do you define these?
Yeah, so it really depends on where you trained and what kind of doctor you are. So it's the radiology doctors will say it differently than the cardiology doctors will say it differently than the surgery doctors, and older doctors will say it differently than younger doctors. So what I would say is anything that sounds weird is not normal. So people use words like ectasia, dilation, and all of those things mean that the aorta is bigger than we would expect it to be. Now, how do we know what to expect? Well, we know based on the fact that we measure the aorta in lots of people with normal aortas, and we kind of know what the range of normal aortas is. So it simply means it's outside the normal range. It doesn't mean if it's big or small or anything like that. It just means keep an eye on this aorta because it's abnormal.
It's a little different. And what is the normal size? I think most people would be surprised.
Yeah, so normally the aorta is around 3 centimeters wide in an adult. And that's from throughout its course. It's a little bit smaller in the abdomen and pelvis than it is in the chest. But overall, 3 centimeters is a good size adult aorta.
Okay. And then we also have a question, the difference between rupture and dissection.
Great question. Yes, a lot of times those are also used interchangeably. And in that case, it's not the same thing. So rupture means a full thickness tear where there's blood outside the aorta. That is, fatal unless, that's an emergency.
Yeah.
If you have a rupture, you're not going to survive until that hole is packed. Dissection doesn't mean blood outside the aorta. It usually means blood traveling inside the wall of the aorta. There's a tear in the wall and blood goes into it, but it doesn't go all the way through the wall. Now the answer, so the two can be related, because if you have a dissection, you are more likely to develop a rupture if that process continues, since there's already a tear there. But in most cases, fortunately, it does not progress to a rupture.
So when you have a dissection, is it only in one layer? Does it go down two? Does it vary person to person?
Yeah, it varies person to person. There are a few general rules in that it usually involves two of the three layers. The aorta has three main layers, and usually the dissection happens between layers 2 and 3, kind of on the outer side of the aorta. And we don't really understand why that is, actually. We see a lot of it, and we'll say, oh, that looks like a typical dissection, but we don't know why is it always in that spot? But I would say in 80 to 90% of cases, it looks very similar, even though the causes could be totally different.
We've talked about maintaining the flexibility of the aorta, and I did have a question. Is that typically the TANs, like losartan? Is it typically that medication that keeps it pliable and flexible? A lot of people ask why they're put on that drug particularly.
Yeah, so the losartan, the TANs, like you said, have been shown to increase the flexibility of the aorta. And that was mostly done in animal studies because it takes years of treatment. So obviously, most patients aren't followed with those kinds of special studies long enough to know. We're trying to gather that data, on people in our clinic because we measure them from time to time. There are different ways to measure stiffness, and some of them used to be very difficult to get. Now we're better at it. So more people, like for instance, if you get an MRI, now they're pretty much able to measure your stiffness, the stiffness of the aorta with the MRI. So that kind of kills two birds with one stone.
Right.
We have machines in clinic that can do it that are not MRIs, that are a little easier to get. So that helps us answer the question, but that's what we think happens anyway at the moment.
Okay. Pseudoaneurysm. We hear that and we get very scared. And it's only because the stories we hear, usually people are going to be having surgery fairly quickly after they're diagnosed with one. Can you explain to people a little bit about pseudoaneurysms?
Yes. So a pseudoaneurysm is another one of those scary things that people have nightmares about. It is a form of rupture in which there is not blood flowing across the hole in the aorta, but it got plugged up by like a blood clot that is just it in place. So it is like one step away from a rupture. So if you have a pseudoaneurysm, it's a very unstable situation, very scary. It means that if you don't do something, there'll be a full rupture and the person will probably pass away. So that's why it's a surgical emergency. And, anytime we see that, it means an operation, like you said.
Yeah. Okay. Why do people have to wait? Watch and wait? Because I've often heard you say, well, if you were a patient and you had this, we probably would consider because you've already had a dissection. And then I have somebody else saying, but wait, my doctor's sitting here saying, well, but you're not really, you're symptomatic. Okay, so let me back up and explain to people. So you have an aneurysm, you've already had a dissection. Let's say you have an ascending aneurysm, so it's coming right out of the heart. And the doctor says, well, you're only at 4.7. We're going to wait. You're somewhat symptomatic. Your valve is moderately insufficient, but you can live with these symptoms. You can live with this. It might be, irritating. It's annoying, but we're going to wait until this grows even more and more. Maybe your valve becomes even more irritating. Why do they tell you to wait? It's going to be a scary operation for us and probably for you guys, no matter what size it is. Is it just because it's so risky? We might as well wait until the last second, or I don't understand that logic at all.
So that really varies depending on the cause of the aneurysm. If we know the gene cause, so if there's a gene mutation in the family, sometimes that will predict when it is likely to dissect or rupture. And then we know based on experience that we should operate earlier, for instance. So that's in a situation where it could make a difference in terms of when we decide to operate. In terms of being reluctant to operate, there are reasons why it is a good idea to wait. So for example, if you had a recent dissection, your doctors might want you to wait to recover your strength and to get to get strong enough to go through a second operation, because it is a big surgery. Even though it's a lot safer than it used to be, it still means a long recovery time, and you can have complications if you're too weak from it. So that would be a good reason to wait, even if you thought, well, maybe the aorta is getting bigger. The other things have to do more with your overall health. There could be other health problems. Sometimes after a dissection, there are things like kidney problems and other issues that make survival complicated and could make it difficult to get through an operation. So maybe your doctors want you to get treatment for those first. So we do often delay operations when we're working on these other things like lung problems, kidney problems. We want people to get stronger because we know that makes a huge difference in terms of how they do after the operation.
You don't know. There's so many people, and people who would say, I'm fine. Like, I don't have any of these problems that he's describing. And yet my doctor's still sitting saying, I would be doing you a disservice if we went in too soon, because there are so many risks. And because it is going to be about a year off of your life, except for those few people who bounce right back and go back to work and living their life 8 weeks later. But it definitely changes things. So then I have to ask this question. Why is it, other than the logic of why is a planned surgery better than an emergency surgery, and yet we wait on the planned? And some people will say, well, I had a dissection and I was 4.5 when I dissected, and now I've got an aneurysm that's like 4.6. What am I waiting for? Well, I've already shown that I can go before that. So I guess, other than you being able to map it out and have things ready to go, you've had a nice dinner or a rest, whatever it is, what makes this planned so much better in waiting versus the emergency?
Yeah, so there are lots of factors that happen outside the health conditions that I mentioned. So some people are very anxious and they don't want to wait. They're saying it's there, it's going to get bigger. I'm convinced there's, why don't we just do it now? I think that's a valid option. And honestly, I will send them to the surgeon and I will say, look, we think that this is a really important part of quality of life, and maybe we should consider doing this, as long as people understand the risks. So, the risk we quote often is something like a 1% chance of dying during the operation. And of course, there are risks after the surgery. As long as people know those risks and they're educated about them and they agree to proceed, I think that we have, it is our obligation to present that as a possibility and then have a reasonable discussion about it. And sometimes we have 2 or 3 discussions, at follow-up visits. Like, is this time? Well, let's reconsider all the options, because it might change 6 months from now. Like, you might be willing to wait now, but 6 months from now, maybe something happened and now you're ready to, you've made the decision. And nothing else has really changed, but that can make all the difference. People have their own timeline, and it has nothing to do with the medical situation or the risk of the operation, which is probably not changed. But we still go through the process, and we tell them, lay everything out, make sure that they have answered all their questions, and then they can decide.
Because when it's an emergency, you don't get any of those options, or if you do, it's read so fast that you just sign your name and you don't recognize your signature when you see it, a week later. But it is interesting to me, because if someone told me there's this 1% risk and I'm like, well, okay, I have shortness of breath, I'll live with it. I also live with, this could change tomorrow for any particular reason. It's still a human body, and it could just decide to dissect tomorrow. And I know people who were on the watch and wait, they weren't ready. And then a week later, after coming home from the hospital from having their scans, they had a dissection. So they lost that opportunity to have it planned. But it sounds like whether it's emergency or planned, it's still going to have the same risk anyway.
Well, emergency surgeries are much, much riskier than planned surgeries. If you take the same operation and you do it as an emergency, it more than doubles the chance of death. Okay. So it is hugely important to try to get everyone done electively. That's my, I always tell people that is our number one goal, is to prevent an emergency, because things do not go as planned in emergencies. It's just impossible.
Yeah.
to prevent all of the complications that can arise.
Okay. Let's go to valves. So we've got mechanical valves, we've got tissue valves. And my first question is, are there 3D individualized printed valves yet?
They're not approved for clinical use, but they're certainly used for predicting operations. So our
Okay.
group uses computer models of the patient's valve to predict how it will respond to different types of surgeries.
Okay.
And that's being done more widely now. Sometimes people will even print them out, but we just view them and turn them around on the computer screen. But either way, the idea is to use them to help design an operation that is unique to the patient and will have a better outcome. In terms of, the best outcome that I see is when we use the patient's own valve and reconstruct it. I think that is far better than using a bioprosthetic valve or a mechanical valve, because the patient's tissue is special designed for that purpose. It's been working. In most cases, it's been working okay up until near the time of the operation. And if we can save it, they also don't have to be on blood thinners or aspirin or anything. It is a known commodity, and it will last a long time if we can salvage it. So that is we go into the operation with that preference and do our best. And I think 95% of the time, we are able to save the patient's valve now, which is really encouraging. It's way up from just 5 or 10 years ago.
And that's called resuspending?
That's right. It's called a valve-sparing root replacement. In general, what happens is the patient's root tissue, the aorta itself around the valve, gets totally cut out, and then the valve itself is sewn into a graft, which replaces the aorta. So the only thing left is the graft and the coronary arteries that come out on each side. The rest of it is all, the only native tissue there is the valve and the coronary arteries.
Okay. Collagen. Is it a fad, or is it something that people should be talking to their doctors about? I one time had a doctor when I asked about glucosamine and chondroitin. I'm probably not pronouncing it right. And he goes, look, if you think it works for you, then you should take it. And that was what he said. And I was like, okay, I'm not going to spend my money. So where are we with this, pouring this liquid, this powder collagen and drinking it down? What are your thoughts?
So the collagen that you drink doesn't go into your aorta. I hate to say it. It gets broken down in your stomach to amino acids. It might make some more proteins elsewhere in your body, but the chances that any of them reach the aorta is pretty low. Okay. So I think in general, it's a fad, and it probably doesn't have any medical relevance to aortic disease.
Okay. Summertime, it's getting hot. I know it's hot where you are, but it was really hot where I am too. People are starting to feel some chest pain. We don't know if it's potentially a heart attack. We don't know if it's just that it's just so ungodly hot and we're dehydrated. We don't know if we're having another dissection. Is there a rule of thumb? I know I've heard, well, try to see if you can make the pain move, shift, take a couple minutes. Because gas pain will make you feel like you're dying. That's for sure. And if you can get anything to shift or come up, maybe the pain goes away. Do you have your own personal, okay, this is what I would do before you got to go get it checked out?
So what I tell patients is that if it's a new type of pain that you've never had before, and it's not getting better after 20 to 30 minutes, so if it's not a transient pain that's going away and coming back, if it's a constant pain, I think is really key, because a lot of times pain, aches and pains will show up and then they'll go away, and then you do a funny movement, it comes back. That's different than aortic pain. Aortic pain stays with you, and it won't go away no matter what you do. And of course, the severity. So if it's more intense than your normal pain, then I would get it checked out. So those three things is basically long lasting, not changing depending on what you do, and of course, just more intense than your usual level of pain.
Okay.
Because a lot of times people do, like you're right, they have musculoskeletal pain, joint pain, all kinds of pains. And so the key is know your usual pain quality and level, and make sure to distinguish it.
And I think a lot of people that are fresh out of having surgery, maybe it's even been a couple months, where we become so hyper in tune with our bodies that we're just not sure. And I would venture to say, if we polled, we would find a lot of people had 1 or 2 ER visits within their first year after having their surgery.
Absolutely. It's very common. And there is no way, that I'm going to convince people that they should not go to the ER. So what I tell them to do is just make sure that they have, they have documented their symptoms and they're able to explain them, as well as their medical history, so that there's no time wasted when they get to the ER.
Exactly. And I have one more question right now on my end before I open it up to what's been coming in through here. Oh my gosh, we hear this all the time. My doctor said my aorta healed. It healed after my dissection. It's all healed up. It's a miracle. I'm not dismissing miracles, but aortas that are dissected do not heal. Correct. It's just another one of those terminologies that we have to just clarify what that means.
Yeah, I mean, so aortas don't get smaller and they don't heal. That's true. There is permanent injury to the aorta after dissection. It is possible for us now to see it because we have better imaging than we used to. In fact, in the old days, people did think the aorta healed because they weren't able to see down into the scar tissue the way we can now. And it's just a matter of, changing the perspective based on the kind of information we're getting. The practical effect is the same, though, that it means that your aorta is fragile for the rest of your life. You have to take care of your aorta. And so that means, number one, lifelong follow-up. Never stop getting your aorta checked, even if it's been stable, even if they tell you there's no aneurysm. It could change, and we've definitely seen that. People who are 20, 30, 40 years out from their operation show up with new aneurysms all the time. This is a fact. And so you really have to take that seriously and make sure that people are aware of your history, and also get checked, because it's really important.
Okay. All right. Thank you for all of that. Now, all the questions that were sent to me have been handled. Okay. Let's take some questions that might be coming in. Josh, what do we have?
Well, first, thank you very much for everything, doctor. That's going to go without saying. We're going to say hi to Christina, hi to Felicia. They were the first couple to drop right in. The first question is going to come from Felicia. Exercise. What's so hard to determine is how can I push myself, or are there BP and HR numbers to signal when you should stop?
Yeah, so one of the issues with blood pressure and heart rate is that so many of people who are living with aortic disease take many different blood pressure medications. So if somebody tells you that this level of blood pressure or heart rate is kind of your moderate zone, that has nothing to do with what our patients see, because they're on like 2 or 3 medications. So their blood pressure might be lower, their heart rate might be a lot slower. If you're taking a beta blocker, your heart rate may not even clear 120 when you're doing moderate exercise. That's perfectly okay. But using those guides for everybody else is not going to be helpful, and it varies from person to person. So I've thrown that out the window in terms of advising people. My answer to you is to use what's called a Borg scale. So it's also called an effort scale, and it's very simple. So if you think of a numbered scale from 1 to 10, where 1 is sitting on your couch watching TV, and 10 is doing the hardest exercise you can imagine. It could be running a marathon or whatever you think is, your maximum that you could never possibly do. You want to be in the 4 to 6 range on that scale. So generally speaking, when you're doing light to moderate exercise, you're able to carry on a conversation. You're not so out of breath that people can't understand you. And if you think of that scale and that kind of provision, most people can find their moderate range pretty easily. And then what we're doing is actually measuring your blood pressure at that level, and we find it, as we predicted, all over the place. So some people have low blood pressures, some people have high blood pressures, some people have low heart rates, some people have high heart rates. There's no one-to-one correlation, and that pretty much bears out the fact that you can't use blood pressure and heart rate to guide your exercise intensity.
Okay, thank you. Karen Bertuzzi showed up and said, what are the rules now to participate in the study? I was originally, maybe 4 years ago, told I could not participate. Has anything changed?
Well, we've only been doing it for a year, so that might have been an old study. In the first version, we were not enrolling people with dissections, and that's because they wouldn't let us. They said it was too risky. So now we're well past that. Fortunately, people have awakened to the reality of the situation, and we're able to enroll. And the criteria for this particular trial is you have to have had a dissection. It could be a type A or type B. Type A is, of course, the ascending aorta. Type B is the descending aorta. And it can be any time, but we are particularly interested in people who have had relatively recent dissections. That is, the reason for that is we want to get people at the early stages when they're adjusting, to being active again, because we think that we can have the biggest long-term impact in that group. But we've enrolled people whose dissections have been 10 or more years ago too, and they just never gotten around to being active. And there are certainly many people like that too. So the key is just having a dissection, and the criteria is it has to be at least 90 days from your acute dissection. So at least 3 months. Anything out from that is fine. If you're currently doing cardiac rehab, we ask you to finish the rehab before you enroll, because we don't want people doing both. It's kind of confusing for one thing, and it also makes it hard for us to measure our progress if you're doing another kind of program at the same time.
It's almost like you read the chat there. Felicia's follow-up question here was, can you participate in this if you're doing cardiac rehab?
Absolutely. You just need to wait until you've been released from rehab, and then we'd be happy to have you.
Okay, great. Let's see. So we have some comments, I believe, when Karen was talking about lifting up her luggage. Karen says, so true, Karen. And then Felicia says, right on point, Karen. I'm scared to carry a purse.
Yeah.
Christina Kohler joined the chat and said, my dissection starts in the left of the arch all the way into the left iliac. How likely is it that it will tear towards the heart in future? My dissection occurred January 2014 and aorta diameter 4.3 centimeters.
Oh, that's a great question. So there are a lot of concerns, in some people that you could have what's called a retrograde dissection, which is that it tears down toward the root instead of towards your legs. And this can happen in certain people. Fortunately, it's relatively rare, and we do know a certain set of risk factors, such as the diameter of the aortic arch, whether things have been changing over time, certain medications that you're taking, and the underlying cause. So certain genetic causes of aneurysms are more likely to do that. And we're getting more information about that all the time. The truth is, for a long time we didn't know, and so we would tell everyone that they were kind of equally at risk, but we know that that's not the case. My feeling is that if yours happened in 2014, then you've probably already passed the greatest risk for that, which is early after the dissection. Usually within the first couple of years is when we really monitor the dissection closely, precisely for that reason. They're worried that it's either going to cause a new aneurysm or go back, dissect toward the root.
Thank you very much. Karen Bertozzi has a question. Is isometric pressure still the biggest concern, as in yoga, lifting, etc.? Is breath awareness enough to release the pressure?
That's a great question. So I mentioned before that if you're doing heavy weightlifting, then breathing becomes super important, because if you're not breathing correctly, you can really ramp up the pressure inside your chest when you're doing lifts. Now, for light to moderate, of course, that is not the same concern. So most people who are doing things like yoga or body weight lifts, where you're holding a position, are not going to be exerting anywhere near the same amount of force. Having said that, it never hurts to learn to breathe properly, which, the movement we're trying to prevent is when you're breathing in, when you're lifting, when you're straining, at the same time. If you do that, then you compound the pressure inside, and that's kind of been referred to as kind of a Valsalva maneuver, where that big grunt that people do when you see them lift weights. So that's what we're trying to avoid by doing slow, steady breathing and making sure that you're not really bearing down and feeling all that pressure inside. So anyone can do that at any level, and it's actually it's something that we look at when we're watching our participants doing their exercises in our trial, because we want them to do it safely. And many people actually haven't been told that. They are trying to do it and possibly not doing it in the safest way. So that's another good reason to have someone watch you and maybe also watch yourself. You can record yourself, and sometimes you don't even realize what your breathing is doing. If you have questions about that.
Okay, thank you. Felicia says, yep, I was told to keep stretching down. So yoga and Pilates?
Mm-hmm. Yeah, yoga and Pilates are I think are very safe options for people who want to get some strength without doing weightlifting, and also increases your activity and flexibility, particularly for people who have joint problems. I think that can be very therapeutic. And in most cases, they're not high intensity. You can start off at a relatively low level. I'm in favor of that because it's also more of a social group activity where you have people with you and you can kind of model how to do it instead of trying to do it by yourself. I think that actually makes it safer in the sense that you are more aware of trying to adapt to different techniques, and you feel more open to learning. I think sometimes we're so closed off in the way we exercise because it's kind of the way things are done that we don't really question it. And it's good to be around people who are maybe doing it a little bit differently than you, so you can learn.
Excellent. Karen asks, do you have to travel to Texas to participate?
No, you can travel to St. Louis or Michigan. So those are the 3 trial sites. We only have 3 because it's a relatively small trial at this stage. But that was done so that people elsewhere in the country at least had one site that might be reasonably close to them. Having said that, we have a lot of people from the West Coast, from the East Coast, and everywhere in between. So people have been managing to get there, which impressed me tremendously when we started this.
That is great. That is great. Felicia asks, so when in the study, you can't do more than the exercises taught?
Actually, you can do whatever you want in addition to the exercises. The only thing we ask is that you document everything you do during those 12 months. So we have an exercise diary where you chart the number of minutes you're doing per week of which type of thing. And many of our participants are doing other things. And we'll just, we talk to them about it when we check in. How much extra are you doing? What kind of other things are you doing? I think that's important because we wanted to make this more of a real world experience where people are going to be in different environments, and we want to show that the experience has a positive effect no matter where you are in the exercise spectrum. That's basically what we set out to show.
That's excellent. Karen Bertuzzi says, Karen, your TikToks count as exercise.
They do, because I have to do them 6 or 7 times before I actually publish it. And if you ever tried to watch one of those 60-second, 2-minute dances, I'm tired after I do it. It's a lot of work, but thank you. Thanks for watching.
Right.
That's great.
So she has a follow-up point to make here. So many folks in cardiac rehab or exercise physiologists have no idea what to do with us. Would be great to have guidelines and a program that could feel confident in giving to aneurysm and dissection folks.
Great. Yeah. So one of the things that I heard about when I was starting the trial, preparing for the trial, is that so few people have access to quality cardiac rehab services. Even where it's available, a lot of times insurance isn't covering it. And then, of course, there's a lot of access issues to where it's just not available. So, we're trying to reach out to these folks and say, yes, you can still benefit from a home exercise program. You don't need a lot of fancy equipment. You don't need to pay for cardiac rehab. But yes, if it gets into the guidelines, the idea would be that then it would be covered by more insurance policies. It would be more accessible. And also there would be guidelines for cardiac rehab with dissection specifically. It would be written in, so there wouldn't be any more questions or any more variation between programs.
I will say, for those people that aren't able to get cardiac rehab, talk to your doctor about getting a script for physical therapy. If you can find a doctor of physical therapy or DPT, they can start you off right away with just learning breath, just learning how to control your breath. You're not going to be able to sit upright and have great posture to start. So they're going to help you with adjusting for that, because you don't want your back to then start hurting. and they're going to really help you with building confidence. Now, one of the main differences is they don't have an EKG or what machine that's watching your heart rate, but they will check your blood pressure, they will check your pulse ox, they will check your heart rate, they will record it and should send those numbers back to your doctor to let them know how you're reacting to basic lower level, no impact exercises. So it's, to me, was similar. I started that before I started cardiac rehab, as we were working through the red tape of insurance. And I continued with PT for years, because I had other issues that would interrupt my exercise. And I just never felt confident to go to the gym by myself. So I felt much more confident in that smaller group setting, having somebody there to check on me and to report back to my doctor how my body was responding. So usually there's not much of an insurance issue when it comes to physical therapy scripts.
Great. Thanks for bringing that up. I've had some great conversations with physical therapists who want to learn about aortic disease. It's not everybody, but if you have someone who's really engaged, then let the community know, because that's a resource that we could all use, honestly.
Absolutely.
There are too few professionals who are not interested in learning or just scared off. And I think that's a shame. It's a real opportunity.
It really is. It truly is. You're right.
I like to hear all of that. And it's, again, interesting. It seems like you're reading my mind. I asked the community here, I said, it's interesting how many in the community have to fight their insurance companies for cardiac rehab. And I asked if anyone here got denied. Karen piped in and said hers was only approved after her aortic valve was repaired.
Yes, and I just heard that today for a patient who had a dissection, and I got a call from the rehab and said, well, we can't approve it unless you write that her valve was repaired. And because she had a resuspended valve, they counted that, but it was just a technicality, you know?
That's what happened to me too.
Yeah, I honestly don't understand why that is. And I think it's another example of where if we had guidelines and people realize the value of this, then that wouldn't be a question anymore. So that's one of my goals with this.
Right, because I think they look at in those moments, the aorta is completely separate from the heart. And so they'll do cardiac rehab if it involves the heart. So
Exactly.
they get really technical.
At least one piece of the heart. And if you can find out one piece, then you're good. But it's such a technicality, and it makes no sense whatsoever. It's just the way the guidelines are written right now. It's ridiculous. So we have to change that.
Yeah.
I agree. In response to cardiac rehab, Felicia says, in cardiac rehab, I just get on the machines with the monitor, and they don't know that it pushes her.
That's a problem. Cardiac rehab should be all-encompassing. You should be riding the bike while watching a video on nutrition. You should be walking on the treadmill and listening to somebody speak about home health or other issues or genetics. I mean, it's a time that you're a captured audience, and they should be educating you if it's a really good, strong cardiac rehab program. And they should be communicating with you, not just sitting there and leaving you to your own devices. I mean, that would be something I would want to communicate. My first moment in cardiac rehab lasted 2 minutes, and then I was done for my first session. I was so done. I was like, I gotta go. But it was what was great was seeing your progress and seeing how much farther I could go. So yeah, that's concerning to me, to just have somebody say, "Okay, glad to see you. Check out when you're done." I'm not sure what's going on there.
Because the assessment is really important, especially when you start. You really need to know that you're safe. That's the reason why we insist on observing people, you know, when they're starting out exercise, because we want to make sure that they're going to be safe. And, you know, you can't do that unless you're paying attention and you're really closely monitoring people during those first minutes of exercise.
I mean, they should be talking to them. I know the last time you referenced PRE, perceived rate of exertion. And I equate it to the pain chart because, well, I look at working out as painful, as punitive for eating. But when you have that pain chart and, you know, you see all the different colors, it goes from green to yellow to red, smiley to extremely frowning. And that's the same thing with the PREs, right? They should be asking you, where do you feel you are on this rate of exertion? Are you like spent? Are you feeling great? Let's pump it up. And they should be noting that as well.
Yes, you should not be starting out at an 8. You know, you want to start out at a 2 or 3 and work your way up. So that would be one immediate clue that you're doing too much right away.
Okay. So Tammy Warner, Tam has joined the chat. Have you ever seen complications from a femoral central line? I had a planned open sternum surgery for an aortic valve replacement and pseudoaneurysm 2 years ago. I've had a lump in the groin.
Yeah, those are quite common, actually. In fact, I had several people who needed subsequent surgery to repair those. They're done in, with not the same care, I would say, as the heart operation part of it. It's kind of an afterthought. The issue is with several kinds of genetic conditions, the arteries are very fragile, and some people refer to them as like tissue paper. So if you go into them with a standard, it's called an arteriotomy, which just basically means cutting a hole in the artery and putting a tube in. Well, that's not going to heal very well. And so our surgeons have now come up with different techniques that are more gentle for people that have arterial conditions and are less likely to cause trauma, because it's basically trauma that doesn't fully heal, like we were talking about with the aorta, except you can feel it because it's close to the skin surface. And that's basically scar tissue that didn't heal from that arteriotomy site. So it is very common, particularly in the population that has aortic dissections. And honestly, surgeons should be aware by now, because there have been so many reported complications of that.
How does that get fixed? How does one go about getting rid of the lump?
Well, in many cases, my patients have had to have grafts or stents put in to stabilize that area, because basically that lump is an unstable segment. And the only way to get rid of it is to remove it and put in a graft in that area.
Okay.
So many of them have had to have additional operations, which is preventable. It's always regrettable when that happens. There is no reason for that to happen now.
Okay, thank you. Let's see here. Then we were talking about the TANs. Karen Bertuzzi asked losartan versus valsartan.
Yeah, so valsartan, losartan, and then increasingly irbesartan are the three most common ones that you hear about. They all work the same way. There isn't a huge difference in terms of their efficacy, either on blood pressure or on the aorta. The main, a lot of times it comes down to which insurance you have and which doctor you have to prescribe your medicines. I would say the most common ones for aortic disease are losartan, because that has been around the longest of the three. So most people are familiar with that one, but I definitely have a lot of patients on the other two, and they do fine. There's no real difference.
Okay. Alexis Rodriguez has a question. Most people are put on beta blockers other than losartan. Do all beta blockers benefit the flexibility of the aorta as losartan?
Great question. The answer is probably not. So there are lots of different types of beta blockers now. Over the past, it used to be basically there were two, atenolol and metoprolol. And now over the past 10 years, there are lots of new ones. Many people aren't even aware that they exist, but a lot of our patients actually do really well on them. So an example would be bisoprolol, or there are several other ones that have weird names.
I'm on nebivolol or Bistolic.
Right, nebivolol, Bistolic, that's a very common one. So there are many options. They all work by slowing the heart rate, but they don't all work the same way in terms of blood pressure and in terms of what they do to the stiffness of the aorta. There's some evidence that medications like nebivolol actually work better than the older medicines like metoprolol and atenolol. We don't have data to show that they actually prevent aortic aneurysms from growing, better than metoprolol. Hopefully we'll get that data in the future. But increasingly we're using more of these new beta blockers, and we're seeing that people actually tolerate them better. One thing I have noticed is that young people who have to be on metoprolol hate it, because it causes a lot of fatigue, a lot of side effects in the 20-something and 30-something. But they seem to do much better with newer beta blockers like nebivolol. And so I've been using them more often, because I feel like taking something is better than nothing in that group.
I can vouch for that. I came home on 900 of labetalol and couldn't remember where I lived when I drove. I was so I mean, every day, hours of naps, just a complete zombie. And within a very short period of time, switching to nebivolol or Bistolic, it was like the cloud just lifted. I was a completely different person. Then it's been a great drug.
Yes, I think it's
other than weight gain. Let me tell you, between menopause and double dose beta blocker, it is like, and then exercise, it doesn't, uphill battle for a lot of women that are in this community that I think end up going into menopause maybe earlier than they would have if they not had the dissection. So that would be an interesting research to do too. But between that and the drug, you are going to see these types of side effects as well, regardless of which beta blocker you're on.
Yeah, so what we typically do when we give people a trial of around 1 month where we'll start a medication and check in with them in a couple weeks. Sometimes we have to adjust the dose. Sometimes we have to switch medications. In most cases, we're able to find it on the second try, but sometimes I've gone 3 or 4, to find something that people can live with, because I tell people you're going to be taking this medicine every day for the rest of your life. It has to be the right medicine for you. Yep. And it will vary. We can't predict necessarily how you're going to do, so we should test it first.
Okay, thank you. When we were talking about testing, Karen Bertozzi chimed in and said, "I totally agree. I'm one of 4 siblings. Mine was emergent. 2 brothers were planned, and brother number 3 is still waiting. And it makes me nuts. What are we waiting for?" And I think that might have been in response to some people they're not willing to watch and wait. They're willing to find out what they can do to push the surgery.
Yeah, I think the concept now is that the decision about surgery should be shared between the patient, the person having the surgery, and the person doing the surgery. It should be a kind of an equal discussion. In the old days, for sure, there was a lot of paternalism, like, we know what's better, we've seen it all, you're going to be fine. Of course, the thing about aortic dissection in general is that it's very hard to predict. So even with the best science, the best medicine, we still can't predict, more than a coin flip, really, who's going to have a dissection, much less when they're going to have it. So I think it's very arrogant for me as a physician to say to you, well, you're going to be fine. We actually don't know. We think that everything is good, but to be honest, there are no guarantees. So if people feel like this, if they want to have that honest discussion, and it's not an easy discussion to have, I think it ends up being more valuable in the long run, because, otherwise it's kind of open-ended. You're like, well, why did it change now? And then nothing seemed to happen on my end. And it just seems so arbitrary. I think it's hard for people to understand.
Okay, that's fair. We want to welcome Molly, Melissa, and John to the chat. They said, hello, everyone.
Hello.
Molly had a question regarding Pilates. How do you feel about planks?
Right. So we actually tried to test planks in our study first, but we had a hard time because it turns out that most people don't do planks very well. I mean, this is probably an open secret, right? So if they're doing them and they're very tense, you can't measure their blood pressure. So instead of planks, we ended up doing leg lifts, because at least then they're stable and we can get a blood pressure. I don't have a problem necessarily with planks if people are doing them correctly. But definitely what we saw is that it's a huge issue, particularly if you haven't done a lot of core activities and you go right to planks. I would say that's probably too harsh. You need to build up to them. And the way I would do it is, leg lifts are a good compromise, because you can lift one leg, you can lift it like an inch, you can go up to 2 inches and gradually build up. But with planks, it's more of an all or nothing type of thing. There are ways to modify them, but it's pretty drastic, I think, if you've never done one, to suddenly do a plank. So my advice would be, it's okay, but maybe do something to build up first and make sure that you're feeling more confident in your core muscles before you engage them that way.
Okay. Melissa Yee just yells out, Los Angeles. She does that sometimes.
All right.
Molly says,
way to go.
Molly says, my apologies for being late. I'm in California, and I'd like to come to Houston for your exercise study. What are the next dates?
So what if you reach out to us, we can tell you the dates. I don't have them off the top of my head. My research coordinator keeps all that information, but as I mentioned, they're on Saturdays. They're between now and the end of August. We can fit you in for sure. And the dates usually, so the way it works is we usually start around 9 or 10 in the morning, and it lasts until 1 or 2 in the afternoon. So it's anywhere from 4 to 5 hours total. And that includes everything, all the paperwork, all of the exercise tests, and everything else that you would need to do.
And if you go to the resources page on Aorticope's website, scroll down to research, click on that, and you'll have all the information there so that you can go ahead and reach out.
Oh, I can put that link in the chat. That's the 2020 research study opportunities available, 2023.
Yeah, that's how far the research stuff started with us when we've been talking. I mean, that goes back that far, yeah. Okay. And I just keep updating and changing and updating and changing. What's next? What's next?
Right on. Okay, so regarding cardiac rehab, Molly has a statement. I did 6 months of it. They treated me as a typical cardiac patient. I felt my type A dissection required more specific program. They need a separate program for dissection patients. And Felicia says, I agree with you, Molly.
Yeah, I think that it's absolutely true, and they don't really know what to do with dissection patients in most places. You're lucky. In some places that do a lot of aortic surgeries, for instance, they'll be more familiar with that. And they do, like in our place, we have an aortic protocol. But in most places, we'll see maybe 1 aortic dissection a year or something, or less, if they're, and so there really isn't any justification for treating them differently. So I think, we just have to be more vocal and get that information out to the community.
I 100% agree. Janet Willits joins the chat, and she says, how many BPM can I go up to while doing 8 to 10 pound weight workout?
So 8 to 10 pound weights, I would assume that you're doing like curls or something, some toning exercise. Your heart rate actually shouldn't go up that much if you're doing them at a low to moderate rate, which is what we do in our study. Most people's heart rates actually, at most go up into the 80s during those, because we really don't want them to be doing them very rapidly. And part of that is because, when you engage your muscles, you want to keep it slow and steady so that you keep that same level of intensity throughout the movement. If you jerk it and you're going fast, you're not getting the same benefit. So my advice to people is to just go slow and steady, and you can increase the amount of weight, but you don't necessarily, in order to get the maximum workout, going faster isn't necessarily better when it comes to lifting like that.
Okay. Let's see here. We're getting toward the end of the chat. Felicia says, yes, indeed. I hate it. Metropolol, talking about the different drugs that we're on. Yeah. Janet Willett says, my doctor has me on enalapril. Is this good for my aneurysm? 4.1 ascending aortic aneurysm.
So, there is not much data about ACE inhibitors. So enalapril is another class of medication called an ACE inhibitor. It's used a lot for high blood pressure, but it's not used for aneurysms. And the reason for that is that there's some clinical trial data, which is indirect, but also some animal model data that aneurysms grew faster in people, in animals, and some people on enalapril or other ACE inhibitors compared to the ARBs like losartan. So that's why we use ARBs and not ACE inhibitors. Having said that, I've certainly encountered my fair share of people with aneurysms on ACE inhibitors because their doctors didn't know, and none of them had dissected. So I don't think we have any solid evidence that it's worse, but we think right now that the choice should be an ARB over an ACE inhibitor if you're able to do that.
And that would be a great conversation to have. That's like one of those perfect examples that we say, take this information back to your doctor, because you're right. Not every, I'm on my second cardiologist, my final one, because the first one just really didn't seem like, number one, I think he was scared of me. I really do. He was a family cardiologist. He had treated my father and his mother, my grandmother. And when I came in, this was very different than heart attack or bypass, this was a whole other world. And I had been on Diavan or lisinopril. I'd been on both till I got a cough. But to have a cardiologist that's very well versed, even if it's congenital heart defects or somebody who's well versed in aortic issues, I think makes a difference. So I would definitely say take this specific question and answer back to your doctor and see if, you know, how they feel about maybe making a switch. I love learning this stuff.
Me too.
It's great.
I didn't see this second follow-up. Felicia called Metropolol the nap snatcher.
Nap snatcher.
Yeah.
Molly says, thank you so much for your time and expertise. It's so appreciated. Melissa says, is there a venue in Los Angeles?
No.
For the trial, sadly, no. I mean, we'd love to expand. As I said, you know, our goal is to do this more because we really think this is just the beginning. And so hopefully in a year or two, you'll hear about a bigger study. That's the goal. And that would include every part of the country. So we'll see if we can get there.
That would be great.
Right on. Janet Willett says, my aneurysm was found on a CAC test, 4.1 ascending aortic aneurysm. I do DVD exercises with weights. Is it okay to be doing them? And how many beats per minute?
Okay, well, we talked about how you can't really use your beats per minute, especially if you're on a beta blocker, for instance. It's not going to be accurate in terms of your activity level. In terms of the weights, it really would depend on the amount of weight you're lifting and how much straining you're doing. And then the speed, you know, you want to do it slow and steady with small amounts of weight that you're not straining to lift. If you're doing that and not getting yourself super fatigued, then you're probably okay.
Is there any benefit to taking your blood pressure before you start a workout like that, and then maybe in the middle of it, stopping, taking it real quick, and then at the end, giving some recovery and seeing how you recover? I mean, would that tell anybody anything?
So it can be important because in many cases, people's blood pressure elevates during exercise and it doesn't fall right away. So if you take it within 3 to 5 minutes after finishing exercise and it's high, chances are it was still high during exercise and it didn't come down. That by itself is concerning. Then what I would tell people, if you find that, then keep taking it every couple minutes until it goes back down and tell me how long it took. So normally what we saw when we did our test with our clinic patients is that some of them didn't come down for 30 minutes, which is kind of alarming. So their blood pressure was up, you know, and is at an okay level for exercise, but then it just stayed there long after they stopped. And that's something that we do see in patients with aortic disease. We think it has to do with abnormal blood pressure regulation at the neurologic level. And because sometimes people have these weird fluctuations in blood pressure, which seems to be part of the same thing, we just don't know why that is right now. But it might be part of the injury or even the cause of the dissection in some people. We just don't have enough information about that.
That's interesting.
Yeah, that's super fascinating. Molly asks, can you provide us with dissection program protocol for cardiac rehab? And if so, I'd like to share with my cardiac rehab at Scripps La in San Diego.
That's a great idea. We don't have a cardiac a dissection protocol for cardiac rehab yet. I think that's a worthy goal, that we make something that's standardized and we put it out there. And my hope is that based on the results of these kinds of studies, that we come up with something that we work with, you know, the rehab team, and we come up with something that everyone can agree on, because it will involve a partnership between the cardiologists and the rehab team, exercise physiologists, to make sure that we're doing things that are the right way. So I wouldn't just force something on them. I think it would need to be a dialogue, but I think that's a great idea.
I agree.
Just add to your list. Just add to the list of things to do.
Yes, absolutely.
Okay.
It's all good stuff.
We have just a few more here. Janet says, thank you, doctor. I'm going next Tuesday and we'll tell him about the ARB. What are the names of the ARB drugs?
The ARB drugs, okay, the most common ones are losartan, valsartan, and irbesartan. Those are the ones that are most widely used, and any of the three, as we said, will probably do about the same for you.
Okay, right on. Tammy Warner says, thank you for your time and willingness to be put on the hot seat with our questions. Marcia says, thank you so much for all the info. Look forward to finding out about the study details. I'm in St. Louis.
Oh, great.
You're already close to our study site. You should go over there to Washington University, and then they can take care of you.
Right on, right on. Let's see here. Janet says, I do take blood pressure before and after, and it seems to be low, which I think you said that was a good thing.
Yes. I mean, that's very reassuring if you do take it and it's low. I think, what we would be concerned about is if there were big changes, then I would recommend in that case that people would check it, would tell their doctors before they continue doing the exercise, because you don't want to put yourself in a situation where you're exposing yourself to unnecessary risk, especially if it's something that's preventable with medication adjustments or other kinds of things your doctor could help with.
Okay. Molly says, I'd like to represent. She's got her hand up. And Christina Clore says, thank you. Hi, Janet, saying hi to Aortic Hope again. We do have an anonymous question. This one rolled in just a little bit ago. She says, it's Marcia. How do I connect with the St. Louis location for the study? Acute type A, emergent graft repair to intramural dissect hematoma, February 2022.
Okay, yeah. So if you call the trial team, they will connect you to the nearest study site. We do that automatically depending on where you tell us you are, and they can give you all the details.
Right on. Let's see. I have developed AFib and now taking metoprolol and Eliquis. This is an anonymous statement. And another one says, hello.
Well, I'm not sure what the question was, but I'm happy to, I would say that in the case of AFib, it does definitely complicates things, and we have a lot of folks with AFib, but make sure that, some of the drugs can interact. And so my thing would be make sure you let your doctor know if you take any new medications, especially for blood pressure.
Okay, right on. Let's see. Thank you from Christina. Thank you so much from Felicia. I'm not sure how to say Jose Cayer. Thank you so much from Clinton, Ontario, Canada. Very informative. Molly says, represent regarding cardiac rehab protocol. Oh, of course. That makes more sense. And that wraps up the chat. Bunch of hearts are floating up. I'm not sure how that happens. It's so awesome.
That's great.
Nice. Thank you, everyone.
Yeah, that's wonderful. Again, if you want additional information about how you can still register to hopefully pass the initial test, to be approved to be a participant in this research study, there's 3 locations. You have Houston, St. Louis, and you have Michigan. Check out the information underneath the resources section. Go to research studies, and you'll see all of that information there. And if you have still additional questions, you can always shoot us a question at info@aortichope.org, and I will zap it right over to Dr. Prakash for all of you. Thank you again so much. I kind of like this format. This is nice to have a chance to interact with everybody like this. And I love learning something new. I actually held back my own questions about myself this time. I gave my space to other people. But no, this was really wonderful. And I learned a lot, actually, in all seriousness, about being able to try to start back up with my own personal exercise or just moving routine, which I like. And now I understand a lot more about watch and weights and everything. So it's always a pleasure to have you on. I always love the opportunity to learn from you every chance I get.
Thank you so much, Karen. And thanks, Joshua, and everyone else at Aortic Hope for making this kind of forum a reality. It really helps a lot of people, and I'm grateful to be a part of it.
Thank you. And don't forget, everybody, click like, click subscribe, click that bell so that you know when we're live again. And we'll see you in about 2 months, right?
That's right.
Okay, wonderful. Thank you all. Have a wonderful night and take care.
Bye.